I should say, in terms of, if I've been trying the various different treatments and they're not working, I start to wonder, is there an underlying hematological issue? I'd like to just ask, who am I talking to here? Am I talking to some adolescent girls, and am I talking to some caregivers, just so that I have an idea of what's going on?
Thanks, Geraldine. I think you're talking to some adolescent girls, some parents, some healthcare workers, and some of the society staff or board members as well.
Okay, so okay. So I have.
Sorry, Geraldine. You can take it that afterwards we'll be advertising the link to all of the parents and to all of the people on our website as well, or on our mailing list.
Okay, great. Okay, thank you. So I'm just going to have a very simple chat, really, about the whole situation, and I'm sort of thinking about it in terms of how I have my consultations with girls in the hospital when I meet them. So if we can move to the next slide then, please, Robert. Thanks. So I think as doctors, we're not really taught how to look after adolescents terribly well, and it's very much a situation where we have to feel our way. And initially, we have to realize that adolescents are not just small or young adults. They're very, very different. Adolescents' brains are very different. They function very differently. We know that by the fact that they're not great first thing in the morning, and our school system isn't great when people have to get up at 6 o'clock to get into school, because that's not when they're at their peak. It's not when a lot of us are at our peak, but certainly not for adolescents. So their brains are really, really developing, and we need to remember that when we're actually having a conversation with an adolescent girl and with her parents, because it's a very different kind of a feel than an adult consultation. Obviously, a lot of girls don't like talking about their periods. It's a very personal issue, and there's a lot of getting around all of that embarrassment and, physiology that's associated with all of this. A lot of the time, I will find that I will get a history, or I'll get the story from the patient, and then when I think I've got a handle on it, then Mum will come in and then will really tell me how bad things are, because girls, and it's actually great to have parents in, because they act, in a very responsible way, and can really elucidate and really explain what's going on for the girl, because it's very difficult for girls to talk about it. It is important, however, that we do listen to the adolescent, and that there's hopefully and that they're heard, and that's very, very important, because a lot of the time it's very important to actually, take what they're thinking or what they're talking to me on board, as well as what the mum or the caregiver is talking about. Adolescents are beginning to take responsibility for their own actions, and that's very difficult for parents who have always taken responsibility for their children's actions. So there can be a little bit of tension there sometimes as well, and that's the normal growing up kind of process. And obviously, we need to try and explain the medical problems, clearly explained, it says on the slide. Sometimes it's not very easy to clearly explain things, because not everything is easily explained. But anyway, so let's move on to the next slide. And then we're talking about periods in adolescence, and we're talking about periods in adolescence with bleeding disorders. So these are usually or can be a lot more difficult for young girls when they have a bleeding disorder. And the three main areas that I'm going to talk about is how much bleeding is normal, pain, which unfortunately is normal, and what the cycle should look like in terms of how often the period should come and all of the rest of it. And there's a lot of anxiety around a lot of these issues, particularly the cycle, because they can be really quite troublesome actually. So let's go on to the next slide, please. So heavy periods, and the vast majority, or a lot of girls with a bleeding disorder, can have very heavy periods, obviously. The old definition, which was really, I don't know who came up with it, of heavy periods, was 80 mils per period. Yeah, like as if we're going to be measuring out how much bleeding we're having. So that's, we've thrown that in the bin. And basically, I try and ask girls, you know, how many pads are we using a day? And that's a fairly basic kind of question. And I often go, you know, are we up to, is it 5, is it 10, is it 15? Is there a lot of leaking? Do we need to be using double pads? Do we need to be using nighttime pads all the time? Do we occasionally need to be using more protection than that, like protective underwear? So that once you're getting into that kind of a situation, there's definitely a problem. Often, you know, girls have to come home from school. This is where we're interfering with lifestyle because they're destroyed, and it's very upsetting because it's very, very embarrassing. You know, and then confidence, which is not often an issue with all the stages of life, but particularly with adolescents, can be very impaired here. Obviously flooding, and the definition of flooding is if you're standing in the shower and the blood's hitting the ground, and that's what flooding is. So a lot of people would get that. And you know, at the start of a period, that might not be the worst, you know, that might not be terribly abnormal, but certainly if by day kind of 2 or 3, you're still really bleeding a lot, then we should be doing something about it. Obviously, anemia is an issue in terms of the bleeding disorders, and certainly we would get a lot of girls with anemia, like due to heavy periods. Occasionally, it's really interesting, which I found in Temple Street, occasionally I would get a young girl, often 11 or 12, having periods. They really don't know how much bleeding is normal. And then they collapse in the shower. And then they're brought into casualty in Temple Street, and their hemoglobin is 4. And you know, they know that they're having periods, they know that they're heavy, but they actually don't know that they're too heavy and that they're causing a problem. And I have had a girl in intensive care with a heavy period at one stage because she was so anemic. So it's really very important actually to know that what's normal and what's not normal. And certainly, you know, if there's a lot of lack of energy and, you know, feeling very weak, there's certainly time to start looking at trying to manage this. If anybody would like to come in and ask questions as I'm going along, I'm very happy to do that, because sometimes you think of a question and then it's kind of gone. So I have no problem with interrupting this and asking and answering questions, or trying to answer questions. So that's really where we are with our heavy periods.
Geraldine, sorry, people can also send in questions on the chat function, and I'll read them out at the end, okay?
Lovely, that's great. The next one, anybody want to come in there? Okay.
Geraldine, Geraldine, Beatrice Nolan here. Can I ask a question?
Yeah.
We get referred a load of girls whose, say, first or second period is heavy.
Yeah.
does starting heavy mean you're going to continue heavy? Do teenagers who are starting, say, the first couple of months when their periods are starting and they're heavy, should you wait to see what happens, or is heavy at the start also abnormal?
No,
Do you know what I mean?
no. Yeah, I know what you mean. No, absolutely. Well, I mean, I see it. Is it, I mean, if it's heavy and if it's causing issues, it's abnormal. But as to what it means down the line, it doesn't mean anything in terms of, are we always going to have heavy periods? No, it doesn't, just because the first, it's chaos at the start of periods because hormones are chaotic, and people can have very prolonged periods, like lasting 2 or 3 weeks on their first period. But usually, and we will get to that in terms of the cycle, usually things do settle down after a couple of years. But often in the meantime, we do have to be managing what's going on. Yeah. So I'm sorry, I have a dog here in the background, but anyway, I'm on my earphones, so I'm hoping you're not hearing her. Is that okay, Beatrice? Okay. So I'm going to go on to pain now, and pain, unfortunately, is part of the package for periods, both for teenagers and for adults. Often pain does improve as we get older, and certainly having really painful periods during adolescence is very normal. Usually the pain comes and it's worst on day 1 or day 2 of the cycle, and we have a very fancy name for that, but it doesn't matter. And usually when I'm talking about pain relief, it's usually necessary on day 1 or day 2 of the period, and maybe for a little bit longer as well. Occasionally we can have pain coming before the period, okay? And if we have an idea that the period is coming and we're getting pain, we should be taking pain relief. And then we can also have other associated symptoms with particularly the first couple of days of the period. And often we can get bowel symptoms such as diarrhea or constipation, nausea or vomiting. And certainly the nausea and vomiting can be a feature of the pain, actually, because if you've got a lot of pain, you'll get sick. And that unfortunately happens. Feeling faint can also happen with pain as opposed to happening with anemia. And again, it's just that you're feeling just really very unwell with the pain. Headaches and migraines can certainly occur with periods, and we have to be a little bit careful with what kind of treatment we're going to give if we have migraine. Basically any underlying condition that we have can get worse with our periods. So for example, I would see a lot of children who have epilepsy, and the usual story is that the seizures have been reasonably well controlled, and then puberty hits and then they go crazy again. It is associated with hormones, and it is associated with periods, and certainly in the run-up, the week before a period, seizures can be really difficult. And other things such as, for example, I've seen a child with cystic fibrosis and her lung symptoms were getting worse. So, if we have a tendency, for example, towards constipation, that's going to get worse probably in the run-up to, and maybe for the first couple of days. So this is all very, very normal and something that we have to try and manage. Do I answer? Okay, so can I get on to the next slide? Thank you very much. So moving on then, we will come back to that. I saw a question coming up, but we might address it a little later about endometriosis, because a lot of people worry about endometriosis. So I will have a chat about that a little bit down the line, if that's okay. So there's a lot of people very concerned about how regular their cycles are. And we know that in actual fact, and most people do not get regular cycles for the first few years after their periods come. And as you can see on this slide, which is a great slide, and research done quite a number of years ago now, only 15% of girls will have regular periods after they start straight off. Okay, really, it's really not a lot of girls. And by the time we're an adult, 12 years down the line, 95% more than likely will have regular periods. As far as I'm concerned, the less often you get periods when you're 13, 14, 15 and 16, the better, as long as you're getting 4 or 5 periods a year. If you're getting 4 or 5 periods a year, that makes sure that your womb stays healthy, that the lining of the womb stays healthy. The only time we actually need to be having regular periods is when we're trying to get pregnant. So there's no issue about a cycle coming every month in my book in terms of looking after teenage girls. And often, a lot of the time, what I try and do if we're trying to manage painful and heavy periods is actually reduce the number of periods girls are getting, because that basically reduces the lifestyle disruption to girls. So, you know, I have a lot of mums are concerned about it because they're thinking about fertility. A lot of girls are saying, well, that's not normal, but you know, it's that we're really applying adult criteria to teenagers, and as we can see, it does change over the years, so that in the vast majority of cases, it does become a lot more regular, and it's not a problem. If we can move on to the next slide, please. Great. So, getting on to management. So, tranexamic acid is our very best friend. We like this for heavy periods, particularly when adolescents are starting off, because if the periods are very, very heavy and very, very troublesome, it's not a hormone, so that we're not interfering with what's happening naturally in the teenager's body, if you like. And tranexamic acid is great medication. I usually start girls on what I call a middle of the road dose, unless the girls are very, very small. We'll always take a weight on for the girls. So if you start kind of in the middle, then we can go up or down in terms of the amount of tranexamic acid that we use. And the way we use it is we just start it at the start of the period and finish it at the end of the period. So you could be taking these tablets for 4 or 5 days, or for 2 or 3 days. Sometimes, depending on how difficult the periods are, if they're not too bad, I would often say, well, wait for a day 1 or day 2, see how it's going, and then if it looks like it's really heavy and it's not getting any lighter, then to start it. Cyclocapron, in combination with what we call these NSAIDs, such as Nurofen or Ponston, actually work together, and they're better together than each of them individually. And obviously, Nurofen and Ponston are also painkillers. The thing about, I don't know whether I'm jumping the gun here on the slides, but the thing about pain is I think I am, is that it's really important to get in early with our pain relief. What happens a lot of the time is, you know, I'm having a period, I don't like having a period, don't want to take the painkillers, this is terrible, and then by the time the pain gets really bad, we've actually missed the boat in terms of the painkiller working well. So as soon as the pain comes, or as soon as the period comes and you know the pain is on the way, certainly for the first 2 days, we should be taking regular pain relief. And I know I've jumped the gun on that. So can we move to the next slide, please? There we are. So I like to use these things called NSAIDs. I think they're better than paracetamol on its own. I always recommend to have it with a glass of milk, because you know your tummy can be a bit upset when you're having a period, and then the Nurofen or the Ponston can add to that. So it's just a nice protectant if you need to be using that. Obviously, not everybody can use these tablets, because if you've got a kidney problem, we can't use these sometimes. So paracetamol, which I find is not a brilliant pain reliever actually, but in addition with codeine, that can work very well as well. But then that can have a few side effects such as constipation and stuff like that. Okay. So then we're on to the treatment of the cycle. So this is where a lot of times for the first, few years, the problem can be what I kind of put into my notes is bleeding all the time with inverted commas. So it's chaos, and people are having a period, bleeding for 5 days, they're stopped for 2 days, they're bleeding for 10 days, it stops maybe or it doesn't. And I would have girls coming in and they're having bleeding for 3 weeks with not much of a break. And that's just a nightmare. So tranexamic acid is not good for this, because tranexamic acid is good for heavy, regular periods. You cannot be taking tranexamic acid all the time. So really, this is the time when we need to have a look at the hormone treatments in terms of trying to make the hormones a little bit more regular, and therefore the periods a little bit more regular. And I will often start on not the pill, but on a Provera, which is a progestin, which is a really good hormone. And again, we've a lot of leeway in terms of the dose of this. And again, depending on the weight of the girl, I'll kind of try and match it up with the dose of Provera that we're giving. And often the way I start it is I'll start it as if it was like a pill. So we would take some tablets maybe for 3 weeks, and I usually say 4 weeks just to try and give it a break. So 4 weeks, and during the time that you're taking the Provera, you shouldn't be bleeding. And then we'll take a break for maybe 5 days, have a period, and then go back on it. And Provera is not a pill, so it's not a contraceptive. We can use Provera in girls where we cannot use estrogen, such as migraine. And it's usually very well received by the mum and by the daughter. Occasionally, and it very much depends on what's going on, occasionally people's appetite can increase a little bit, and there can be a little bit of weight gain. But that's not the Provera, that's the appetite, is the way I try and to talk about it. So we just need to be aware of it and not start eating a little bit more than we're used to. It's the Provera itself doesn't put on weight, but it makes us eat more. And very occasionally it can have an effect on mood. And certainly that's something, again, to be aware of, but it doesn't happen very often. So the next thing then, so the idea then is you're taking it for 4 weeks, no bleeding, 5 days bleeding, 4 weeks, no bleeding. If that works really well, we can make that longer. We can make 3 months of taking Provera, no period, happy days, and then have your break, and then on we go. So that works really very well for a lot of girls. And then similarly with the oral contraceptive pill, we can certainly use that in a very similar way. So again, the oral contraceptive pill is usually for 3 weeks with 1 week break, but I've started to shorten that week break to maybe 5 days to reduce the length of the period, and then go back on it. And again, if that works very well, we can run it for 3 packs, 4 packs. There seems to be a tendency at the moment to start people on a pill and to say, you don't ever need to take a break. I'm not really sure that that's a great idea, because I think eventually you're going to get what we call breakthrough bleeding, which is bleeding while you're taking the tablets, and then because you get a bit of a build-up. So I think it is important to have a period from time to time. How exactly does the pill work? Right. Well, let me just answer that. So we've got estrogen and progesterone in the pill, and they're a relatively medium to relatively high doses. So what they do is they stop our ovaries from releasing estrogen and progesterone, and they stop our ovaries from releasing an egg. And what normally happens during the first part of our menstrual cycle, before we release an egg, we've got a lot of estrogen going on there. And then when we ovulate and we release the egg, we've got a lot of progesterone going on there. And it's usually that causes a lot of issues in terms of mood and in terms of constipation and stuff like that. And what the pill does is it just flattens that all out, and it stops you releasing an egg. And it just keeps the hormones very regular, if you like. So we don't get a big buildup of hormones. So we don't get a big buildup of the lining of the womb. So we don't get a big period. I think that's possibly the best way to describe that. So usually, I mean, I will, in terms of the length of time, 12, 18 months is what I put down here, because I think given what we've seen before with cycles and the fact that 15% of cycles are regular at the start, so in other words, 75% of cycles or 85% of cycles are really irregular for the first couple of years. So I like to come off it maybe after a period of time, and then let's see what the periods are doing, because often it's just a matter of getting people over the hump, if you like, and then their own system has matured, and then the cycle is usually fairly okay. So we'll go on to the next slide, please. So we're nearly at the end of this because I always do these things quite quickly. So ovarian cysts are I can't see that one, Shannon, but I'll come back to it. Ovarian cysts are really quite common in young girls. And again, it's because the hormone situation is not particularly regularized. And what I say is to my patients is what happens is that our ovaries get mixed messages from our hormones. And then the ovary, it makes a cyst rather than a little follicle. So what happens when we release an egg is a little blister, it's like a little blister on the surface of the ovary. And when that pops, we release an egg, and that's normal. And some girls will get, and some women will get a little bit of pain around about the time that they ovulate. And that's actually really normal. But sometimes what happens with adolescents is that because the hormones are a little bit chaotic, instead of having a little blister, it becomes more like a small bubble, and that can be a cyst. And sometimes then that can cause a little bit of pain. So it's not unusual at all for girls to come into the emergency department with a lot of pain, and an ultrasound scan is done and we'll find a cyst. I very rarely operate on those cysts because the vast majority, 98% of these cysts, go away themselves. It's just a matter of taking pain relief, and they usually resolve spontaneously, as I say. Even cysts up to 7 or 8 centimeters, I usually tend to sit on those because we do not want to be operating on young girls and causing issues down the line because they've had lots of operations, or they've even had just one operation in the past. So normally what I would do is we would repeat that ultrasound scan maybe about 6 to 8 weeks later, and it's usually gone. It's really quite remarkable. And the way I look at this is that this is actually nearly a good thing, because it means that you are actually ovulating. It means that your ovaries are actually working and that you are releasing eggs. Occasionally, I will have girls coming in And they'll have this kind of thing happens, you know, maybe twice or three times, and it's really not a very nice thing to happen. And those are the type of girls we need to put on some form of contraception. So, for example, a pill, or for example, any other type of contraceptive, which I'll get onto, which will actually stop ovarian cysts, because they'll stop the follicles developing and they'll stop us releasing an egg. So that's a really common thing. And again, I usually would keep people on some form of contraceptive for a year to 18 months, let things settle down, let the system develop, and then come off it, unless, of course, we need it for contraception down the line, which is another day's work. So I think we have one last slide. So these are all various different types of contraceptives that I would use. So the pill obviously is the go-to. So, you know, we can take a pill by mouth, we can take a pill, if you like, by a patch. So we just, you can just put on a pill once a week, and that contains the hormones, which is really nice, because sometimes people can forget to take the tablets every day, but then sometimes people can forget to change the patch every week as well. So it does, I always say to put a reminder in your phone if you need to be taking regular medication. Other thing actually, just to mention about the pill, is that there's a lot of talk about you must take it at the same time every day. That's not essential. You know, for example, if you're going to school, in the days when we were going to school, if you're up at 6 o'clock taking your pill during the week, you do not have to be waking up at 6 o'clock at the weekend to take them. You know, it's not that exact at all. It is good to remember to take them, but if you forget to take a pill, you just take and you're looking at your packet the next day and you go, uh-oh, just take the 2 tablets and keep going. It's really important to keep going with them. If you've missed 3 or 4 days, well, then it's probably best to give yourself a break and then to start a new packet, and you will have a bleed at that time. So Depo-Provera then. Depo-Provera is it's a contraceptive. It works extremely well for a lot of girls. It's a bit like the Provera, except it's an injection, and we give it every 3 months or every 12 weeks. I would use it a lot in girls with significant problems with epilepsy, because it just stops the periods, it stops the hormones from cycling, and it stops the seizures often from being a problem. It's a really good contraceptive. It's been around for ages, so it's an extremely safe form of contraceptive, and it's an extremely safe medication in general. However, there are downsides to Depo-Provera. Depo-Provera is quite a high dose because we're only giving it every 3 months. So it would have similar side effects, if you like, to the Provera, in which are weight gain, maybe, and mood changes, maybe. And whereas if we have those kind of side effects with Provera, we can just stop taking the tablets. If we have it with Depo-Provera, we can't take the injection out. So we have to kind of ride the storm. So I often would put people on Provera initially, see how they get on with it. And if they're thinking this is good, then we might consider going on Depo-Provera. The other problem with Depo-Provera is that we can only really use it for about 3 years, because if we use it for longer than 3 years, it can interfere with bones. The most important time for developing our maximum bone density is in late teenagehood and in early adult life. So we don't want to interfere with developing good, healthy bones. So occasionally I have people who really don't want to come off their Depo-Provera, but we have to look at alternatives if they've been on it for longer than 3 years. The Implanon is, it's the bar. It's what people call the bar. It goes on the inside of your arm. It's a really, really good contraceptive. I'm not convinced it's great for periods personally. I've had a lot of girls come into me with bleeding problems, and then when we find out what they're taking, they're on Implanon. Again, it's the same hormone. We give progesterone, which is Provera, in lots of different ways. So tablets, injections, and this little thing called the bar, the Implanon. But I find particularly for adolescent girls, I find that it's not great in terms of looking after the periods. So I don't personally use this in the age group, but it is an extremely effective form of contraception, as I say. The Mirena coil, again, is a form. I should have a picture of that. Actually, I'm sorry, I don't. Is a progestogen as well, and it's like a T-shaped plastic white piece of kit, and it's really very small. And I will use that often. For example, if girls have really difficult periods, and if we've gone through all the other options, the Mirena coil works very well. For people who are not sexually active, I will usually bring them into the operating theatre. We'll put them asleep and pop it in. It takes about 5 minutes. It stays for 5 years, and then we can remove it and put another one in, or remove it or not put another one in, depending on what the girl and the situation is at the time. It's an extremely good form of contraceptive. It's what I call the Rolls Royce for contraception. And the effect of it is that it keeps the lining of the womb very, very thin. So that, again, with adolescents, they might not get no periods. Certainly in older women, you put in a Mirena, it often stops the periods entirely for 5 years, which is a gift. But for adolescents, again, because the hormones are a little bit crazy, that often doesn't happen where you get no periods, but you can get very, very light periods, a little bit irregular, and that's fine, because you're not having the normal regular cycles that you would be having necessarily. And often people get away with just a liner from time to time, like a little panty liner. Occasionally people can get a bit of pain after having the Mirena in, and that's very normal, but usually after a few days, the pain will stop. Bleeding can be a little bit all over the shop for 3 to 6 months, but eventually then it tends to settle down. So I usually don't, if people are kind of going, oh, I don't like this and I'm not sure about it and it's not working great, I kind of try and encourage people to stay with it for 4 to 6 months anyway. That is all I have today. So if anybody would like to ask me any questions, that would be great.
Thank you, Geraldine. You had a question about endometriosis. Is it more common for girls with bleeding disorders to get endometriosis? First question.
Right, very good question. I don't actually know the answer to that, except I would say that the heavier the periods, the more likely it is to have endometriosis. So yes, if the periods are very heavy, yeah, I would say so, yeah. Yeah.
There's a question, how exactly does the pill work?
Yes, I think I addressed that actually when during the thing. I saw that coming up, yeah.
And do you ever have caregivers or parents rejecting the idea of their, say, teenage daughter taking progesterone or the pill?
Absolutely. Yeah, and certainly the pill, because people are concerned. There's a lot of anxiety about taking a pill, because there's an awful lot of stories about the pill, really, in terms of, will it cause problems with fertility down the line? And the short answer to that is no. And people will often have stories about, well, people have gone on the pill and then when they came off the pill, their periods never came back. That's usually a condition called polycystic ovary disease that the pill was masking. So polycystic ovary disease is the condition where, again, it's a hormonal imbalance. And it means that people's periods are very irregular. and that condition is associated with difficulty getting pregnant. But the pill itself does not cause that. It's just been giving that person regular periods all the time, because that's what the pill does. And then when we stop it and there's no periods, then we're into the situation where it's another condition that has been masked by taking the pill. Obviously, there are concerns about, you know, if you go on a pill, is my daughter going to start having sex? And that's a real concern for a lot of patients. Or a lot of parents. Interestingly, a study was done over in the UK a few years ago on this very topic, because it's obviously something that is concerning. And they, in the group that they studied, where it was girls needing pills for menstrual problems, in actual fact, the number of girls having intercourse didn't increase statistically at all.
Okay. Beatrice has a question. Beatrice, if you want to ask it rather than me ask it. Just so I don't know how we went off in the chat. You can unmute. While we're waiting, I'll go on to another question, Geraldine. Do you notice more problems with fertility in women with bleeding disorders compared to the normal population?
Not at all.
Okay.
No, not at all.
And Beatrice's question...
Except to say, I suppose, to say, if you have endometriosis, you can have fertility problems. And if you've been having very, very heavy periods all your life, you're likely to have a little bit more likely to have endometriosis, and that can interfere with fertility. But hopefully we'll be able to manage the very heavy periods, and therefore, yeah. But of itself, a bleeding disorder does not cause a problem with fertility.
Okay. Beatrice now has two questions posted. Beatrice, can you...
Yeah,
I just
want to ask the questions that people ask me in the clinic, if that's okay.
Yeah.
So, do any of the hormone treatments affect your ability to have children down the road when you stop the hormone?
No, I think I kind of vaguely addressed that when I was saying about people being concerned about teenage girls going on the pill. No, except to say that occasionally people may have underlying polycystic ovary disease, which has been masked by the pill. And then when we stop the pill, the periods disappear. But no, from a long term, I suppose, I mean, it depends on how long you've been on the pill. If you've been on the pill for 30 years, it's probably going to interfere with your fertility. And this is why I like to make sure that we come off the pill from time to time and just see how the periods are going. But no, in the main, normal use of the pill and of contraception does not cause infertility in the long run. With the injection, with the Depo-Provera, you can spend quite a bit of time waiting for your period to come once you've stopped it, because it is quite a high dose hormone. So it would not be unusual to be waiting for a period for maybe 6 months after stopping the injection. But once the periods come back, then there's no issue at all.
And then the other question that, a teenager is started on the pill, and after 6 months they come in and they're all disappointed because it's made no change at all. So, I mean, how long should you give a pill? And, is it typical for the first preparation you get to work? Or do girls move through, say, one pill doesn't really do much, the next one doesn't really do much? Should you keep trying,
Yeah. I think 6 months is a reasonable length of time to say it's not working. Always say to people, leave it for 3 months anyway. Okay. I certainly would try a second different type of pill. But I think after that, if the combined pill, the oral contraceptive pill, is not working, we need to be thinking about moving on to something else. It's always a bit of a heart sink when I see somebody coming in and they've been on 4 different pills in 12 months. And actually, Beatrice, what I normally do in that stage is I stop everything for a while and see what's going on, because A, it's 12 months down the line from when they had the period. B, the pill just does not suit some girls. And sometimes it's just good to see what's going on with their own hormones without interference, if you like, from the pill. Yeah. So I wouldn't be going
And
more
then
than two pills really. Yeah.
before moving on to the Depo
Well,
Provera,
before
is it?
moving on to some kind of
Something else.
Provera or something like that, yeah, or Depo, yeah, or
And then
Marina.
my last question that I was just asking is, you've gone through the pill and you've moved on to the Depo. How old would you have to be before you'd consider the Marina? Or what's the age of the youngest girl you've put a coil in for, the Marina coil?
I'm going to put one in on Monday in a 13-year-old.
Fair
Now,
enough.
that's not usual, but she's a very tall girl, and she has autism, and autistic girls have really, really, really difficult problems managing periods. But
Yeah.
she's about 5'9". I usually would say 16. Yeah, I usually kind of leave it till about 16. And just because, if the girl is small, the womb is small, and, it might just be a bit uncomfortable for a while. So I kind of tend to leave it until they're around about 16 in the main. Yeah.
Another question,
Thanks,
Geraldine.
Geraldine.
Do you regularly monitor iron levels, and do you recommend prescribing iron supplements?
Yeah, I saw that, and I actually don't. Beatrice does that. A lot of GPs do that, and I actually don't, and maybe I should. Yeah.
Or liver and cabbage diet?
Yeah, and well, certainly. I mean, obviously, a lot of these girls that I would see in Temple Street who've come in with a really, really low iron levels would have been seen by hematology there and would be on iron and stuff like that. But it's not something I do probably often enough, to be honest. Yeah.
There's a question for
Actually,
both of you about prophylaxis. If these approaches that you've talked about don't work, Geraldine, if they're not enough, is intermittent prophylaxis an approach that would be taken for girls with an underlying bleeding disorder?
Prophylaxis of?
This is for Beatrice, I suppose. What
bleeding
factor
Yeah, it is.
concentrate?
Yeah, we do.
Yeah.
But it's usually only, it might be DDAVP for girls with von Willebrand disease. It might be factor for girls, if they have severe factor 8 or 9 or 10 deficiency. So it depends on the underlying bleeding disorder. There aren't many girls with who are on prophylaxis other than the pill or a Depo or the Marina. But so it's not something we typically do, but we do if it's not controlled with the hormonal preparations. But in terms of the iron, I was going to say it's remarkable the number of girls with heavy bleeding disorders who have normal hemoglobins
Yeah,
and normal
yeah.
iron.
And yeah, I think over the years I have found that. So it's kind of I've kind of haven't been doing the iron levels very much. Yeah,
Yeah,
it is remarkable.
and
Yeah.
and there are we do check it because we're
Sure.
hematologists,
Yeah. Yeah.
so we do check we check an FBC and a ferritin, so that's
Yes.
your body's iron,
Yes.
and we would prescribe iron, but there's studies coming out that shown iron every second day is as good
Yes.
as iron every day.
Absolutely.
So,
Yeah. Yeah.
yeah, so you
Because
can the effect, is as good every second day as every day.
exactly. Because like with pregnancy, we're aware of that because iron can be nasty to take, and particularly in pregnancy when you're a little bit nauseated anyway. So we would often say alternate days. Yeah.
And the other thing we used to do was, I used to do thyroid function tests, and I
Yeah.
don't think there's any evidence really. I don't think I've stopped doing thyroid function tests, just
Yeah.
in girls with heavy periods, because I've never in all the years found a
Yeah.
single girl with an underactive thyroid or an overactive thyroid with heavy periods.
Yeah. And again, I have done that for years, and I'm wondering, am I wasting my time? Yeah.
Geraldine, another question. An
Yeah.
issue we raised some years ago, and I don't think it's been resolved, is should the manufacturers of tampons or sanitary towels have a notice on the back of the package saying, if you use more than so many per month, you should consult a doctor or a GP or a hematologist?
Absolutely. I think that would be a great advance, particularly for these very young girls who are starting out and they really don't know what's normal. And And I know that young girls are very good at reading the packaging, because young girls can always tell you what medication they are on, unlike us older people. So yeah, I think that would be a really, really good thing to be doing. Yeah,
because I think one of our other concerns is that if the young girl starts having heavy periods and she asks her mother or sister, they may also, for example, have von Willebrand. So it's normal
and
for
it's
that
normal
family.
for them. Yeah, absolutely. Yeah, exactly. Yeah,
okay.
Yeah. And a lot of people who would, a lot of girls who would come in with really severe anemia are actually from ethnic minorities, and their diet is different to ours, and they would be more susceptible to anemia anyway. So it's really important, to look at the whole kind of picture in terms of the likelihood of developing anemia. But as I say, and Beatrice the girl who comes in to my clinic with heavy periods, 98% of them have a normal hemoglobin. But the girls who are sent to me from the A&E department are the girls, it's funny, I don't get to see those girls who have heavy periods who develop anemia, except that they've developed anemia and they come to me then. It's really, really an interesting kind of phenomenon, yeah.
And in terms of diet, you said that some of them would have a different diet. Are you talking, is there more likely to be a problem if they're vegetarian or vegan?
Yeah, that's a really interesting, I'm very interested in all of that. Again, from years of doing obstetrics and looking after pregnant women and looking at they would be flagged, vegetarian, likely to become anemic. If you're a good vegetarian and if you have the appropriate diet, you are no more likely to become anemic than if you're eating meat. The problem is that it's a different way of life to not being vegetarian, and you have to be very aware of what's an iron-rich food. So a lot of times people are experimenting with vegetarianism and they're not getting the appropriate iron-rich food. So yes, then you would be more likely. Yeah.
Do we have any other questions? Beatrice, go ahead.
Brian, can I just say something? Sometimes any girl who comes into Crumlin with heavy periods into the emergency department is referred to us for investigation for bleeding disorder, and
What?
GPs
You poor thing.
GPs refer an awful lot of girls with heavy periods. About a third might have a bleeding disorder, but even the girls who come in with really, really heavy bleeding, even say dropping their blood count and needing a transfusion, sometimes even those girls don't end up having a bleeding disorder.
Yeah.
So we see girls, maybe their first 2 or 3 periods are really, really heavy.
Yeah.
And
then they do tend to settle. Yeah.
Yeah. And so so about a third of girls that we see with heavy periods will have a bleeding disorder, but about 2/3 have heavy periods.
Yeah.
For no known
For
reason,
no known
really.
reason. Yeah. And that's why, like, what we do in gynae is, like, we, with heavy periods, we will go through the whole gamut of the treatment, and then if that doesn't work, that's when I send them to you. So it's a different, there isn't a gynecologist in Crumlin.
No, there isn't a gynecologist in
So
Crumlin.
that might be, yeah. So that's.
Well, there isn't an adolescent gynecologist in Tala. There isn't an adolescent gynecologist in Crumlin. So
and there isn't any more in Tala either.
Yeah, no, Patricia Crowley used to do
well
adolescent.
retired. Yeah, that's right. Yeah,
so it's a shame that we, I know you're in Temple Street, Geraldine, but it's a shame that we have to refer out all the time.
Yeah.
We can't. There's no in-house gynecologist.
Yeah.
So every girl that's seen in Crumlin gets referred out.
Yeah, that's
sometimes
right.
They want to go locally because they're, so we see girls from all over the country. So sometimes they want to go to the gynecologist their mum sees.
Yeah.
Sometimes they want to go to, sometimes
the local.
they go to school. So they go to the local, but there's very little designated adolescent gynecology around the country, I think.
You're absolutely right. We're and with the new hospital and all the rest of it, we're looking to appoint another 2, and we're actually making an application at the moment for 1. Yeah. So that's,
that would be
I'm
great.
hope
that would
is
be
going
great.
to yeah, because it's I mean, it's, you know, it's a bit of a, it's a huge, I'm aware of a huge need actually, and a huge lack of service for girls with gynae issues, not just bleeding problems or heavy periods. Yeah, it's I'm really well, there's a girl in Holles Street who does a little bit of this, and then there's a girl down in Cork who does a little bit of this, and that's it at the moment for adolescents. So we're actually trying to change that, and I think as adolescence becomes more visible in terms of needs and stuff like that, I think it's beginning to change. But
Beatrice mentioned that 1/3 of the girls referred into Crumlin with heavy periods have an underlying bleeding disorder. That's still quite a lot, and it's a lot of girls who wouldn't be diagnosed otherwise, perhaps.
Yeah, it's much more. If you were to take an older woman with heavy periods, you wouldn't get that percentage. It's the girls presenting in adolescence have a higher percentage of bleeding disorders than the older women, you know, coming in with heavy periods. So, and the other thing I was going to say is, like, we've seen girls start their periods in 3rd and 4th class.
Yes.
They're 8 and 9.
I know.
So, you know, and you're talking about adolescent gynecology, they haven't even made it that far, you know. So if an 8-year-old or a 9-year-old with heavy periods is a hard enough,
that's awful.
a hard enough situation.
Yeah.
And it's
Is
not
that
unusual.
due to better diet in this generation?
Yeah.
Yeah.
It's due to increased calories, in a lot of the time, and sometimes that, you know, you do get a genetic kind of a thing where you will get girls having very early periods, and then if you chat to their mums have had them, and their sisters have had them very early. But like if we were to catch that before they got their periods, in terms of, you know, a 7 or an 8-year-old having pubertal development and having breast development and all the rest of it, I mean, referral to endocrinology can delay the onset of early periods. But by the time they're menstruating, you can't turn back the clock, but you can delay the clock by delaying the onset of puberty, if you get them at a reasonable time. Yeah.
So would you necessarily put an 8 or 9-year-old who'd started menstruating on the pill?
No. In general terms, no. Definitely not. Yeah. And you wouldn't, because
endocrinology.
I beg your pardon?
Sorry, when we see a girl of 8 or 9 with heavy periods, we end up usually referring them to endocrinology.
I know it's no harm. It's no harm to do that, but I don't think they're going to give them a GnR, like a medication to try and reverse it, you know. But it's important to kind of look for other reasons, I suppose, as to why they're having that period so soon, too early.
Geraldine's question: at what point would you prescribe a blood transfusion?
Well, I'll give that to Beatrice, really. You know,
we try and avoid it if at all possible. Yeah, we would try and avoid it if at all possible. If somebody is walking around and able to manage their normal daily activities, then we wouldn't. But if somebody comes into hospital and their blood pressure is a bit low and their heart rate is a bit high, and they're kind of, it's called hemodynamically unstable, so their circulation is compromised, and their heartbeat has gone up to maintain the oxygen, to send blood around the body to maintain oxygenation, then that's the situation where we might consider transfusion. But we wouldn't transfuse, say your normal hemoglobin is 11 and you come in with a hemoglobin of 4, we might go to 6, but we wouldn't go to 11 with a transfusion. We try and get away with as little as possible, so just enough to calm everything down. So we do get calls about girls with hemoglobin of 4 and 5, and if their heart rate and blood pressure is fine, then we give them iron. If their heart rate and blood pressure is not okay, we'd give them a little blood, you know, and reassess, and then iron after that. So we wouldn't, the days where you would sort of transfuse someone back to a hemoglobin of 11 are kind of gone, really.
Yeah.
Well, I think the risk-benefit ratio view of blood transfusion has changed remarkably in the last 20 or 30 years. It's now seen as a last resort, not the first thing you do.
Yeah.
Okay, if we have no further questions, Geraldine, thank you very much for a great Zoom call. Greatly appreciated. And we've already had a request from our European organisation to put it on their website as well. So
Great.
will be going out there. Thank you very much, Geraldine.
And thank you to Robert for sorting a very nervous Nelly out in terms of the technology. Thank you very much, everybody.
Okay.
Thank you.
Thanks, Geraldine. Bye-bye.
Bye now.
Thanks, Geraldine. Thanks a million.
Thanks, Beatrice.
Thanks,
Cheerio.
Geraldine.
Bye. Bye-bye.
Good again. Bye-bye.